What's up, guys? Finally time to do that NBME 18 stream. I'm a lot better now, but I'm still just really congested sometimes. It comes and goes, it's weird. But I'm almost done recovering from this viral cold I have. So let's get this done with. NBME 18 has been pretty interesting. I couldn't find a good clean form for the test, but I was able to take little snippets out like that and then paste it here and put an explanation in. The main thing I've noticed in NBME 18 so far is that it is pretty hard. But it's a good NBME. I haven't seen anything ridiculous so far. I'm not done going through the whole thing yet. I think I've only really done explanations up to the 42nd question. So I haven't even finished the first 50 question explanations yet. Just because I've been resting a lot and all that. But it doesn't seem like the most ridiculous one so far. I've seen some interesting questions. I don't entirely know why people were requesting it, but a lot of people were really saying I should definitely do NBME 18 explanations. It was high yield or something. So let's see what it's like. So far I'm done with 42 questions and I haven't seen anything ridiculous, but it is a good test. It's definitely a good test. I've been enjoying going through the explanations for it and all that. So we can get started now. Let me just disgustingly sneeze out my nose real quick. Oh yeah. Yeah, it feels like I'm not recovering, but I definitely have gotten better. Let's mute this up. Okay. Alright, so let's do this. Number one. Hold on, sorry. No, I'm not done yet. This is so annoying to be sick and shit. Yep, sneezing my nose on a live stream. That's what it's come down to now. Okay. Alright, number one. 63-year-old man is brought to the physician because of a 2-week history of a sensation of fullness in the left upper quadrant of the abdomen. He also has had lethargy and occasional shortness of breath during this period. He's had a 20-pound weight loss during the past 3 months. Physical exam shows pallor. The spleen tip is palpated, and lab studies show low hemoglobin, a 27% hematocrit, 4,000 leukocyte count, and a uric acid count of 15, which you may or might not know if it's normal or not. It's kind of hard to figure that out from there, but it's slightly higher than what it's supposed to be, as far as I know. A peripheral blood smear shows numerous erythrocytes with abnormal shapes and sizes, nucleated erythrocytes, and myelocytes. So that's pretty diagnostic. And then aspiration of the bone marrow results in a dry tap, which is also very diagnostic. A bone marrow biopsy specimen shows markedly thickened bony trabeculae with increased reticulum. Which of the following is the most likely diagnosis? So then you look at your answer choices. Now, you're looking at a patient who's 63. They've been losing weight. The spleen is palpable, so they have splenomegaly. They do have anemia, right, because hemoglobin is low. And then when you see numerous erythrocytes at abnormal shapes and sizes, that's like poikilocytosis, something like that. And nucleated erythrocytes are like immature erythrocytes, right, because a red blood cell is not supposed to have its nucleus at all. And then myelocytes, you're seeing myelocytes too. So now you're starting to wonder, what's happening with this person and why have a dry tap? Dry taps are pretty rare. You don't get a dry tap in just everybody, And one of the things you have to remember from dry taps is that when you have a dry tap, remember that the red blood cell sheds a tear. It looks like a teardrop cell, the dacrocyte thing. So that might be one of the abnormal shapes and sizes they're seeing in the peripheral blood smear. So you look at all your answer choices: AML, CML, dysmyelopoietic syndrome, essential thrombocythemia, myelofibrosis, and polycythemia vera. Of all the answer choices, the one that you can immediately knock out is polycythemia vera because the person has a low hemoglobin. He has anemia. In polycythemia, you would have more red blood cells. You would have higher hemoglobin, not lower hemoglobin. Myelofibrosis should immediately ring a bell when you do see it, and that is the answer here. Because when you have fibrosis, right, that's like actual myelofibrosis, that is one of the case scenarios where you do get a dry tap. So that was the correct answer here. Page 466, which, let me show you so you know what the actual page is. 466 is actually the page number from my own PDF. It is page 425 of First Aid 2019. Is where they discuss chronic myeloproliferative disorders. And excuse me for being so ridiculously sick. So this patient has a dry tap, which is seen in myelofibrosis and aplastic anemia. Those are the two high-yield major things that you're going to have on your test where you can have a dry tap. The abnormal red blood cells are most likely dacrocytes, which are teardrop cells. And then when you look at myelofibrosis, it's right here, obliteration of the bone marrow with fibrosis due to high fibroblast activity, often associated with massive splenomegaly, as we saw in our patient, and a teardrop red blood cell that looks like these guys right here, right? These are dacrocytes. Bone marrow is crying because it's fibrosed and is a dry tap, all right? Teardrop cells are dacrocytes. You would also see poikilocytosis too, which is the abnormal shapes and sizes. And anisopoikilocytosis is like a mixture of abnormal sizes and shapes. NBME also had the same topic in another NBME, where they called it agnogenic myeloid metaplasia, right? Just another name for myelofibrosis. This is something NBME loves doing. They like to use less common names of things so that you might not recognize it in an answer choice. And the only way you would end up picking agnogenic myeloid metaplasia is either because you can actually make sense of those words or because all the other answer choices did not fit the patient that you were looking at, right? So that's kind of what they do. So that's an important note to have. So, you know, it's always important to catch. I like talking about things that are repeated on NBME. So those are things you want to make sure you know if you're actually preparing for a comp exam. Now, how do you knock out the other answer choices? AML would have hour rods and many circulating myeloblasts, but not abnormal red blood cells, right? So remember, AML is aged men leukemia, and aged men leukemia, aged men walk with, canes, so that's how you remember the hour rods, okay? CML is defined by the T922 Philadelphia chromosome, and it will have many mature and maturing granulocytes with the low LAP, leukocyte alkaline phosphatase, because this is not a leukemoid reaction, right? So in CML, you do see a difference, an entire spectra of red blood cells and white blood cells and stuff like that. Not red blood cells, just entire spectra of white blood cells. But it's not because you're trying to fight an infection; it's because you have cancer, right? So that's where LAP is significant. That's how you figure out, like, why is this person having so many maturing white blood cells? Is it because they're fighting infection, or is it cancer? Dysmyelopoietic syndrome you probably never saw somewhere. It's actually the same thing as myelodysplastic syndrome, which are a group of cancers with immature red blood cells in the bone marrow that do not become mature. But that was not what our patient's problem was. All right, so again, this is another example of them using a less common name for something you probably have seen. Myelodysplastic syndrome you definitely read in first aid. Dysmyelopoietic syndrome is just a weird way to name it. So if you did want to read more about it, there's a link for that on Wikipedia. But that's basically it. It wasn't relevant to this patient though. And then essential thrombocythemia, which is right here, is not essential polycythemia. So really important to understand that, right? This is called thrombocythemia. Thrombo is really related to platelets. So essential thrombocythemia is like the platelet version of essential polycythemia. It's just a rare cancer with high platelets, which presents with abnormal blood clotting, leading to thrombosis, strokes, and pulmonary embolism. Polycythemia vera we knocked out first, right? That's the one that has very large red blood cell mass and low erythropoietin due to the negative feedback. It's due to a JAK2 mutation and also has high white blood cells and platelets, but our patient is actually anemic, so it's the opposite of our case. All right, so that was number one. Number two, a 4-year-old boy, which is patient 32, right? A 4-year-old boy has had a clumsy gait for the past year. Examination shows calf hypertrophy and proximal muscle weakness. Serum creatine kinase activity is increased. Muscle biopsy shows a loss of muscle tissue, regenerating muscle fibers, and fibrosis. A maternal uncle, person 2-3, which is the guy with the line through him, had similar findings and died at age 15, which is why he has a line through him. Okay. The patient's 20-year-old sister, which is this circle right here, is pregnant. And ultrasonography identifies a male fetus. Which of the following is the probability that this male fetus has inherited the disorder? So this is actually a pretty easy question. You can't really entirely tell which type of muscular dystrophy this question might be about, but generally speaking, muscular dystrophies, it's either going to be Duchenne or Becker here, and they're both X-linked recessive. So you should be able to do the calculations using that concept. The mother, who is 3-1 right here, has a 50% chance of being a carrier, right? Because definitely right here, the mother must have been a carrier. We don't know anything about this man over here, okay? And they had 2 kids, one of which has the disease. So definitely this woman over here, she has a 50% chance of being a carrier, or she might not be a carrier at all. So you that's how you calculate that aspect. The father, right, which is 3-2, has a 50% chance of giving the defective X chromosome to her son. Okay, so now, wait, let me see. Where did that come from? Wait, that's actually, I might have actually done this explanation incorrectly, because that is not the father, that they're siblings, right? The father 3-2 will not be giving anything to the offspring. What was the question? Which of the following is probably that this male fetus has inherited this disorder? Yeah, her fetus. She's pregnant. We don't know anything about her husband though. I'm gonna have to come back to this and do it over again. Let me just put a mark for myself. I know the answer is C though, but when I was writing the explanation, I definitely made a mistake, so I'll come back to that later. Because I probably wasn't thinking correctly, and I ended up acting as if they're the ones getting married, but they're actually siblings. So I'll come back to that later. We'll move on to number 3 for now. A previously healthy 65-year-old woman comes to the emergency department because of a 6-hour history of fever and shaking chills. 4 hours ago, she took 4 325 milligram aspirin tablets for her fever. Her temperature is 39.4, so it's really, really high. Pulse is 96 per minute, respirations are 18, blood pressure is 102/60. Physical exam shows marked tenderness bilaterally in the costovertebral areas. Lab studies show alright hemoglobin, 39% hematocrit, 32,000 leukocyte count, which is high, and then her urine has nitrites and leukocyte esterase. So it seems like she has a UTI. A photomicrograph of a right stained peripheral blood smear is shown. Which of the following is the most likely cause of this patient's leukocytes? So you can tell she has infection, and she's got a lot of leukocytes. This same peripheral smear could also be used for CML, right? And the main difference between the two is CML and Leukemoid reaction. The main difference between the two is that one of them is actually to fight infection, which she has, right? She has the costovertebral tenderness, she has the fever, she has the urine analysis that tells you she has infection. So this would just be D, a Leukemoid reaction, right? This patient has a UTI, as evident from her urine analysis. She is making neutrophils to fight infection, so her leukocyte alkaline phosphatase would be high, but they didn't give you that. This benign neutrophilia is compared to CML on page 465, where LAP is low because it's a cancer, not a reaction to fight infection. So already, like in just the first 2 questions we've done here, we can see that this whole concept of leukemia and all of that is pretty significant, right? So when you look at CML is right here, and they talk about CML having very low leukocyte alkaline phosphatase because they're not actually fighting infection, right? This is as a result of low activity in malignant neutrophils. Whereas in benign neutrophilia, which is a leukemoid reaction, those neutrophils are not malignant, those are actually being made to fight infection. LAP will be high. Right? So this is a pretty significant comparison that often comes up. Make sure you know it. Number 4, a 1-year-old boy is brought to the physician by his mother because of a rash in the past 2 weeks. He is at the 10th percentile for length and weight. Physical exam shows a scaly seborrheic eruption over the scalp, palms, back, diaper region, and soles of the feet. So 1-year-old boy with all this. There's also generalized lymphadenopathy and hepatosplenomegaly. X-rays of the skull show a few osteolytic lesions. So osteolytic lesions in the skull. Electron microscopy of a biopsy specimen of a skin lesion shows a tennis racket-shaped bilamellar granule in the cytoplasm of cells. And when they mention this tennis racket-shaped thing, that's pretty pathognomonic. You should immediately know what's wrong with the patient. Immunohistochemical studies of the abnormal cells show CD1A antigen expression. The abnormal cells in this patient are most likely derived from which of the following? And this was kind of a fucked up question, because even if you knew exactly what was wrong, this question is kind of testing you on your actual understanding of like where things come from, right? Where is it derived from? So this is actually Langerhans cell histiocytosis. That's the only time they ever mention a tennis racket-shaped cell or anything like that. So 468, that's like still in the same chapter, which is, you know, pretty interesting. We haven't really left Hem/Onc yet. So this is Langerhans cell histiocytosis, collective group of proliferative disorders of Langerhans cells. You can see this osteolytic lesion right here in this skull, right, presents in a child as lytic bone lesions and skin rash, or as recurrent otitis media with the mass involving the mastoid bone. Cells are functionally immature and do not effectively stimulate primary T cells via antigen presentation. Cells express S100 and CD1A, Burbeck granules, right, tennis rackets, or rod-shaped on EM are characteristic, as you can see right here. Right, so these Burbeck granules are the thing that they refer to as tennis racket-shaped granules in this question as well, right, bilamellar granule. So now, the question was, what are these cells derived from? That's the hard part. You look at all your answer choices: dendritic cells, keratinocytes, mast cells, Merkel cells, and T lymphocytes. One that you can immediately knock out, you know it's not derived from T lymphocytes. Like, that doesn't make any sense. You should also be able to knock out mast cells. This is not derived from mast cells at all. Then you're just left with dendritic, keratinocyte, and Merkel. You should also kind of be able to knock out keratinocytes. That's not relevant here. Right? Keratinocytes, you think more for like keratin type stuff. This isn't that. Now, between Merkel and dendritic, that's where it becomes a little difficult, and a couple people actually wanted to pick dendritic cells as an answer choice. But this is actually coming from Merkel cells, right? These cells express S100 because of their mesodermal origin. The tennis racket are Burbeck granules seen on electron microscopy. Langerhans cells are dendritic cells in the epidermis that have an immunologic function. They are derived from the bone marrow, right? So the Langerhans cells itself were the dendritic stuff, but this stuff came from Merkel cells, all right? So definitely make sure you are aware of this kind of stuff. Let me just make sure, actually. What am I saying, right? Hold on, I'm sorry, guys. This is actually, it is A, it's dendritic cells. I was probably writing dendritic and left it as D. Merkel cells are like a, thank you, Harry. I'm telling you, man, like, I've been doing this real slow because I've been really sick and sleepy all the time. But good thing I have everything written down. Langerhans cells are dendritic cells, right? And this is a dendritic cell. Merkel should ring a bell for the pressure receptors that you have under your skin. Remember that stuff? There was a bunch of different ones. There's the Ruffini, there's the Merkel, all those different receptors. This isn't one of those guys either, so you would knock out Merkel cells. Langerhans cells are dendritic cells, and they teach you that here too. Right? Proliferative disorders of Langerhans cells, the way they're talking about it. And so you have to make sure you know. All they put here actually in first aid was that it's mesodermal origin. So I added in the note that Langerhans cells are dendritic cells. And you just have to memorize that. You know, it's not a very high-yield topic. It's not a very high-yield topic, but like I don't even think UWorld, maybe UWorld has one question, but I don't even think UWorld really put much emphasis on this topic of Langerhans cells. So just make sure, you know, when you get questions like this, be ready to knock answer choices out so you can at least increase the chances of getting it correct, you know. And you should have definitely been able to knock out B, C, and E. Those three do not make any relevant sense at all. And when you're down between D and A, if you remember that Merkel cells, Ruffini receptors, and those other free nerve endings, they're all pressure receptors, then you'd be able to knock out D as well, and you would just be left with A. All right, so A, dendritic cells. That's what Langerhans cells are from. And always remember this kind of description. A really, really young little child with lytic bone lesions is not related to vitamin D, it's not related to osteogenesis or any of that stuff, and they'll mention this tennis racket-shaped bilamellar granule. When they mention that, it's histiocytosis, and then you just go with it. Number 5. A 2-month-old boy is brought to the physician for a well child examination. The mother has no concerns about his growth or breastfeeding habits and says that he has begun to smile. He is at the 25th percentile for length and 30th percentile for weight. Cardiac exam shows a blowing holosystolic murmur heard best over the lower left sternal border. Which of the following is the most likely cause of the cardiac findings in this patient? Okay, so then, you got a pretty good explanation of what's wrong with this baby. And if you've been studying cardiovascular, if you're pretty confident with it, you should know immediately what's most likely wrong with this baby. So a holosystolic murmur in a 2-month-old boy, you're thinking congenital cardiac anomaly, and you need to figure out, remember those congenital anomalies are separated in 2 categories. It's either early cyanosis or later cyanosis. And this, when you look at all your answer choices, coarctation of the aorta, functional murmur, patent ductus arteriosus, patent foramen ovale, and VSD. You really should be able to knock out at least 2 of these answer choices, and then figure out like how the patient will be presenting for those scenarios, and then be able to pick the correct answer. So this is how you would do it. Here the correct answer is E. It's a VSD. The child clearly has a congenital cardiac anomaly, and the VSD is the most common of them all. On page, it's not 317 for you guys, it's 297, first day 2019. Here you see the VSD is the most common congenital cardiac defect, and the way you're supposed to remember these guys as the later ones is VAPE later, right? So VAPE stands for VSD, ASD, PDA, and Eisenmenger, right? They have later cyanosis, so VAPE later. ASD, the S in ASD reminds you that the secundum type is more common, right? So that's just like a memorization tool right there. And our child in this question has a VSD. So how would you get there? In addition, there are only 2 holosystolic murmurs in the lower left sternal border, either a VSD or a tricuspid regurgitation. And you know this is not a tricuspid regurgitation. In fact, that's not even one of your answer choices. On step 1, it probably would be one of your answer choices. But, again, tricuspid regurgitation isn't even really that likely in a 2-month-old boy, even if it was one of your answer choices. The VSD flow is from the left ventricle to the right ventricle. And when I did my cardiovascular videos, I talked about how flow vectors are the best way to understand how you would hear murmurs and where you would hear them, because that is what you're hearing. You're hearing the flow of blood, and you're hearing the closing of valves and stuff. So the VSD flows from the left ventricle to the right ventricle, and the left ventricle is on the back of the body, the right ventricle is in the front, so you hear blood coming from the back towards the front, and you hear it on the lower left sternal border, because that's just how the heart is oriented in our chest. So that's why you're hearing it the way you hear it in this patient. And how would the others sound? Coarctation of the aorta would probably be symptomatic much later on, like significantly later on. It would not have any cardiac murmurs per se, unless the patient has other heart defects or a bicuspid aortic valve. The main findings in coarctation of the aorta are the brachiofemoral delay, a collateral intercostal arteries for getting the blood around, eroded ribs. Under the rib there's going to be erosion because of the dilated blood vessels under there from the collateral supply, and complications of cerebral hemorrhage and heart failure that can follow because it's a really big problematic issue. Which question was that? Wait, which question was that? Oh, question 4. Oh, yeah. Okay. Yeah, this one. Definitely a weird question. I mean, they didn't even really ask you about what's in first aid. They picked on something that's not there, so I guess it does a good job teaching you something, per se. But they did pick good answer choices, so I'll give them that. They picked good answer choices that you should have been able to knock out, so I'm glad I was able to explain the wrong answer choices. So that's coarctation of the aorta, a really big problematic issue. We can actually take a look at it right here, right? So this is how you would have it. This is the coarctation. So then to get, the issue happens that blood comes into the aorta, it goes to your upper extremities just fine, but it can't really make it to the descending aorta. So that's how you get the brachial, right? You get the brachiofemoral delay because there isn't enough blood going down there, right? And let me see, I think they have that. Yeah, they have the brachiofemoral delay here, right? And then you get, with age, right? So that's why it'll present much later on. As you grow up, the intercostal arteries enlarge to make available collateral blood supply, like that, right? And these arteries are under the ribs, so you have, blood is inflammatory. Blood will cause this erosion to occur, right? And that's something you will see later on. And you will had a question where a guy, 22-year-old guy, randomly had a severe intracranial hemorrhage. It was because he was actually someone who probably had coarctation of the aorta, and coarctation of the aorta has a high risk of cerebral hemorrhage because you have a lot of blood you're sending to the brain. A lot of the blood that was supposed to go into the descending aorta is just being sent into the upper extremities and your brain, and that increases a lot of different possibilities that you can be opened up to. So that was that. A functional murmur is an innocent or physiological murmur due to conditions outside of the heart, not structural defects inside the heart itself. A PDA is another high-yield topic. So the two answer choices you should have been able to knock out are A and C immediately. Right? A PDA is a high-yield topic. It allows blood from the aorta to come back into the pulmonary arteries and go to the lungs once again. Key findings here include a differential cyanosis in the legs due to the descending aorta not having as much oxygenated blood, and a continuous machine-like murmur, which is the main finding you would have had. Right? And they didn't describe a continuous machine-like murmur for the patent ductus arteriosus. Right? Remember that? Let me see. I think I have another good picture for that too. Yeah, this one right here. You see? So what happens here is this is your ductus arteriosus right here. It didn't go away. It's patent. It stayed. So since it stayed, blood that came into here comes back in here and goes to your lungs. So this is very similar to the coarctation aspect in the sense that blood is only staying in the ascending aorta and going up, but not to the descending aorta. However, in coarctation of the aorta, you get a brachiofemoral delay because you don't even send any blood down there. It's very, very low amounts of blood being sent. It takes a longer time for the blood to be sent to the descending aorta because of the collateral pathway. So you have the delay there. Whereas in PDA, you're sending blood down, but it's not enough. Most of the oxygenated blood actually goes back down here and goes back to the lungs. So in this case scenario, you get the differential cyanosis. There's no cyanosis in the upper extremities, but there is a cyanosis in the lower extremities. Right, so that's the main difference there. Patent foramen ovale is also a very high yield topic, but it can often be confusing to pick between that and ASD and a VSD. But you have to remember this is a test about what's most common, right? VSD is most common. Patent foramen ovale, which is different from an ASD in the sense that a patent foramen ovale has unfused septa, whereas an ASD is actually missing tissue. That's the biggest difference between the two things. But a PFO allows blood to flow from the right atrium into the left atrium, which can make it possible to have a paradoxical emboli. And you learn about that in the earlier sections of cardiovascular, right in the first page, right? Patent foramen ovale, right here, right? So this is the thing that allows you to possibly have paradoxical emboli. Right? Something that should have gone to your legs maybe and caused, not legs, something that should have gone to your lungs and caused a pulmonary emboli ended up instead going into like systemic arterial blood supply and maybe cause a stroke or something, or a DVT. Right? So that's the paradoxical emboli, and that's not our kids' issue either. Okay? So really good, like cardiovascular is, the hardest chapter of first aid, and neurology is the longest chapter of first aid. So you really want to make sure you spend enough time with those two guys. You got to keep coming back to cardiovascular, keep refreshing the pathologies, keep refreshing the heart murmurs. Those are things you should know very, very well as if you're already practicing, and it takes time. Number 6, this was an easy question. Like everyone should have at least 15 versions of this question. Like 45-year-old man comes to the physician for an annual health maintenance examination. He's 6 feet tall and weighs 190 pounds. BMI is okay. CBC shows no abnormalities. Average of 2 fasting serum lipid studies show cholesterol of 200, HDL of 50, so LDL is 150, triglycerides of 550. In addition to suggesting lifestyle changes, it's most appropriate for the physician to prescribe which of the following drugs. Now, patients usually don't listen to lifestyle changes, or if they do, it takes them a long time to finally, adapt it, and they might actually quit it later. So giving the medication is very important. And if you look at his labs, the most significant thing is this really, really high triglycerides, far above 300, right? So you have to give him a medication that helps him lower triglycerides. At which point, the immediate thing you should think of is some kind of fibrate, and that's answer choice C. This patient mainly has high triglyceride levels, so giving a fibrate will be beneficial. Remember that fibrates upregulate LPL, lipoprotein lipase, and activate PPAR alpha. Patients may get cholesterol gallstones due to the 7-alpha hydroxylase inhibition. Cholesterol, answer choice A, is a bile acid resin that reduces LDL by not reabsorbing bile acids, which can cause GI upset and loss of fat-soluble vitamins. Ezetimibe is similar. It also reduces LDL by preventing cholesterol absorption, and that can cause diarrhea. Orlistat is a medication that you can buy yourself over the counter. This came out, I was really, really young when this first came out, but when this did come out, it was all over the TV. Like, there were commercials every day. It's marketed in America as Alli, A-L-L-I is the name it's sold under. You could actually buy the medication. I think it was like $50 for a month's supply or something. And the price started going up as people started buying it. What it does is it's a weight loss pill. It inhibits gastric and pancreatic lipase, decreasing the absorption of dietary fats, but causing steatorrhea and loss of fat-soluble vitamins. So basically, everything you eat, you just won't absorb it. All the fatty stuff, you won't absorb it. You're just going to end up pooping it all out, which is why you would have the steatorrhea. Right? The dangers of taking this were the fact that you need to absorb fats to absorb fat-soluble vitamins. And if you have people who are already deficient in some fat-soluble vitamin, it can lead to very significant side effects, right? Because vitamin E, for example, is extremely significant. Vitamin K is obviously very important. And then A and D are the lesser end of how important they are. So that's what orlistat does. Simvastatin, we all know statins, right? They reduce LDL by inhibiting HMG-CoA reductase and upregulating LDL receptors, so you can pick it all up. And, one of the other ways that I always talk about answering questions is figuring out which one of these is not like the others, and you can kind of see that, right? Fenofibrate is the only one that's not like the others. All the others are going to help much more with the LDL aspect. Fenofibrate is the only one, if you remember, it helps with triglycerides, then you should be able to pick that answer choice. Number 7. A 60-year-old man comes to a physician for routine health maintenance examination. He's had normal blood pressure measurements. His blood pressure today is 170/95. Physical exam shows no other abnormalities. Serum studies show hypokalemia and metabolic alkalosis. Plasma renin activity and serum aldosterone concentrations are increased. Following the administration of captopril, there is a marked increase in plasma renin activity. Which of the following is the most likely cause of the findings in this patient? So one of the important things they told you here, and NBME, believe me, loves this question to death. They are bringing this topic up, sometimes even twice in the same test. Like, I haven't finished NBME 18, but I'm pretty sure they'll have another question on the same topic. The most important thing to understand here is that giving an ACE inhibitor caused renin activity to further increase, right? When that happens, anytime that happens, you pick answer choice E. This is a very high yield topic on NBME. And it's a pretty important topic for step 1 too, because they can definitely ask you about this. So what's happening here? The renin-angiotensin system causes a decrease in GFR, right? Leading to a rise in renin, which amps up the RAAS and causes hypertension, right? Now, the renal artery stenosis causes a decrease in GFR, leading to a rise in renin and amping up the renin-angiotensin-aldosterone system and causes hypertension. And this is like the basics of physiology for how renin works, and you should know that very well, right? So renal artery stenosis does that. The administration of an ACE inhibitor to such a patient will further increase the renin, okay? That doesn't happen with like normal people who have hypertension for any other reason, right? So like if you have essential hypertension, for example, that's answer choice D. That was the bait answer choice that a lot of people picked. A lot of people wanted to pick D. Some of the forums that I was checking for NBME 18, everyone kind of fell for answer choice D, which goes to show you they weren't really studying enough, because if you are studying for NBME, you would have seen any of these questions already and you would know this topic, right? Essential hypertension is where we give ACE inhibitors, and when you give ACE inhibitors to them, their renin will go up a little bit, but not much more. Here, with renal artery stenosis, it goes up way too high. So ACE inhibitors are actually contraindicated in patients with bilateral renal artery stenosis due to a risk of azotemia resulting from the preferential efferent arteriolar vasodilation in the renal glomerulus due to inhibition of angiotensin II. That's exactly what an ACE inhibitor does. The elevated renin will cause more aldosterone activity, which will lead to retention of sodium and loss of potassium and H+, as you can see in this patient, who is presenting with hypokalemic metabolic alkalosis. And they gave you that. He has hypokalemia and metabolic alkalosis. When you see those two things together, that's excessive aldosterone activity. And remember that renin isn't just related to angiotensin. When you give somebody an ACE inhibitor, you kind of just stop the angiotensin aspect of things. But the aldosterone aspect of things, you're not really stopping per se, right? And in renal artery stenosis patients, it's that aldosterone aspect that gets much worse, right? And giving captopril will only make it significantly worse. So that's why they have this other answer choice here to also bait you, right? Aldosterone secreting adrenal tumor. But that's not what this patient has either. Now, this topic is in first aid, but they don't, they obviously don't talk about it a shit ton. But it's here, right? Renal vascular disease, page 592 of First Aid 2019. I put the question here too because I felt like it was significant. They didn't really mention everything, but they do a good job at least making it clear how a patient would present, right? So renal impairment due to ischemia from renal artery stenosis or some kind of microvascular disease like atherosclerosis of the renal arteries. This causes a decrease in renal perfusion in either one or both kidneys. That causes you to have more renin release because the kidney senses low blood flow. That causes an increase in angiotensin and you get hypertension. The main causes are going to be one of these two things, both of which are very high yield, either atherosclerosis or fibromuscular dysplasia, which is usually a middle-aged female. Clinically, patients can have refractory hypertension with negative family history of hypertension, asymmetric renal size, and epigastric flank bruits. Right, this is the most common cause of secondary hypertension in adults. Other large vessels are often involved, especially if it's an atherosclerotic plaque. That means you might have atherosclerosis in your coronary arteries and other places like that. Okay, so they didn't write it here, but the fact of the matter is, for these patients, you cannot give ACE inhibitors. That's why I put this question here. Really important to understand that aspect. They should include it here too. ACE inhibitors do increase renin in normal patients, yes. Patients who have essential hypertension, when you give them ACE inhibitors, it'll also increase renin. But here, in renal vascular disease, these patients, their renin is already high. Whereas in like essential hypertension, before taking ACE inhibitors, in essential hypertension, your renin isn't already high. It's essential hypertension. You have hypertension from some other reason, but not because of renin. Right? So patients who have essential hypertension will have, I checked statistics on this. They said that about 60% of people have normal renin, 20% had high, 20% had low. They did it on I think it was 3,000 people they checked for that. But generally speaking, the main thing you want to remember is that essential hypertension patients will have normal levels of renin, right? It's not going to be significantly higher. Whereas in people with renal artery stenosis, their renin is very high. Now, when you give them ACE inhibitors, it's going to be even higher. Whereas a patient with essential hypertension, their renin is normal. You start giving them ACE inhibitors, their renin gets a little higher, but it won't cause any kind of major issues. Their blood pressure will be under control. Here, in renal vascular disease, when you give these patients an ACE inhibitor, their blood pressure gets worse. They're not going to feel any better, and this is like a classic question for such a scenario. This question has been in every NBME I have done so far. I've done 20, I've done 23, this is 18, it's here too, right? Oh, and I looked at 21 also, that also had it. I haven't done the videos for it, but NBME 21 also had a question on renal artery stenosis, so be ready for that. Number 8, a 19-year-old woman comes to a physician because of a 2-day history of pain in her left index finger. She injured it during a softball game when catching a ball. Physical exam shows erythema of the left index finger. The patient is unable to flex the distal phalanx when the proximal interphalangeal joint and metacarpophalangeal joints are restrained. Right, so basically, she's unable to do this, right? Just flexing the distal part. while these guys are restrained. And they're doing the index finger. So yeah, she's unable to just flex this upper portion right up here, the distal interphalangeal joint. Lab studies and x-rays of the left hand show no abnormalities. Which of the following structures is most likely injured in this patient? So you know what must be injured if you know your anatomy. And you can immediately cut out as choices E and F, because those two nerves would only really be injured in like either a carpal tunnel kind of thing, right? Or some kind of bone in your palm. One of those bones, all of those bones are actually relevant to these nerves here. So it wasn't about that at all. It had to do with one of the answer choices A through D. And you have to remember the way these are named, it actually tells you where they go. First of all, in the question they told you she was having issues flexing. Right? The patient is unable to flex the distal phalanx, so you can knock out A and B also. So you're really down to a 50-50 choice between C and D. Now, profundus and superficialis, those names are actually based off of how far they reach. Profundus is very profound. It goes all the way to the end. So it comes from your elbow area all the way to the tip. That's the profound one. That's flexor digitorum profundus. Superficialis doesn't go that far. It's actually up to like your proximal interphalangeal joint. It comes almost there. So it's the one that helps you do everything else with your finger. But the distal one is the profundus tendon. I have a picture for that in my book, 485. So let's take a look. So that would be this image right here. So you see the blue one, right? That's your flexor digitorum profundus. You see how it goes all the way to the tip. All the way to the tip. Right? And flexor digitorum superficialis, I don't have a picture for it, but it would only reach up to middle, like right here. Okay? So that's the main difference between them. You can see the flexor digitorum profundus right here. The medial part is ulnar nerve. The lateral part is median nerve. Okay? So I've never had trouble remembering that, because the easier way to remember would have been medial median, but that's not what happens. So I tell myself that's not what happened. So the medial part of it is actually ulnar nerve, and the lateral part of it is the median nerve. Okay? So you got to make sure you kind of remember that. It is easy though, because you know everything here is ulnar nerve, and remember anatomical positioning. So the medial part is this stuff right here. This is medial. Your thumb is lateral. So you know these two guys are ulnar, these two are median, and you shouldn't have any major trouble remembering that. Flexor digitorum superficialis right here. This is all median nerve. It flexes the middle phalanges of the medial 4 digits, and the proximal phalanges weakly. Okay, but not entirely. So this thing inserts at the bodies of the middle phalanges, right? So just the middle area right here. Okay, so these are just pictures I got. I put them into my first aid that I sell. The images come from teachmeanatomy.com, and these tables come from Netter's Anatomy. Right, so together they do a good job helping you really visualize and memorize all the things you need to know. So it was a good way to actually like put this stuff here. And that's what this question was about, so not too bad. Number 9, a 32-year-old with HIV infection comes to the physician for a follow-up exam. He has been treated with highly active antiretroviral therapy for the past 6 years, during which time his plasma HIV viral load has been undetectable. His plasma HIV viral load has now increased, and antiretroviral resistance is suspected. HIV genotype analysis confirms that the virus has resistance mutations. Based on this finding, which of the following is the most likely mutated? Excuse me. Okay, HIV is another topic that every NBME was on. Mainly the treatment of. They like testing you on those medications right there. So when you come here, HIV therapy, page 203 of microbiology, antimicrobials, they love testing you on like the side effects. Some of them have very unique ones, like abacavir, ABC. ABC is pretty significant because it's contraindicated in patients who might have this bullshit mutation, right? It can cause hypersensitivity reactions in them. The others, they like asking about what you can give them to help, right, medication-wise. And then from these two, enfivrotide and maraviroc, they like testing you on the various receptors and whatnot. So this is a pretty easy page. You know, these medications are not that hard to memorize side effects of, and it just takes a little bit of time. They have very annoying names, I totally agree. But the good thing is protease inhibitors, they all end in navir. Integrase are all tegra, right? So those are good. There's only 3 NNRTIs, and you can memorize them. Anything else is an NRTI. Okay, so that's kind of how you should approach that. So for our question, this guy was on heart therapy, right? And then he's getting resistances. So now you should know that the majority of heart consist of NRTIs and protease inhibitors, among others, right? But the majority of heart treatment is actually to use NRTIs and NNRTIs. These are the mainstay of the treatment. Yeah, okay. So now, if he's getting resistance to it, he must be getting resistance to those NRTIs, and the only way to get resistance to that would be answer choice E, right? Reverse transcriptase and protease. Those are the places where the resistance must be occurring. Those guys must be mutating so much that the medication no longer can affect it, okay? Remember that NRTIs, they inhibit nucleoside binding by binding to the reverse transcriptase and terminate DNA chain, thereby not really allowing your viral load to go up. And protease inhibitors, they affect the assembly of virions, right? This HIV-1 protease, which comes from the POL gene, cleaves the polypeptide products of HIV mRNA into their functional parts. If you stop the cleaving, you'll never make the functional parts. So you take protease inhibitors for that. But if your protease is mutated, you will no longer be able to inhibit it, and that's kind of what's wrong with this guy. So his HIV viral load is now successfully increasing because he's able to function. His HIV is able to function correctly. So what are these other answer choices? Choice B is the one that makes no sense. That one you should have immediately knocked out. CD4 and CCR5. A patient might have mutations in their CCR5 receptor, and if they have homozygous mutations, if we as humans have more homozygous mutations in CCR5, that would actually make us immune to HIV, because HIV uses that receptor to kind of infect us. Answer choice C, NEF and VPR. NEF and VPR are mentioned along with VIF as part of the viral protease. Those are different proteases, and that was not the correct answer choice. TAT and REV, answer choice F. TAT and REV are regulatory elements of HIV-1, while NEF, VPR, and VIF, as well as VPU and plenty others, are accessory proteins not essential for replication in some tissues. Alright, so remember that GAG provides the basic physical infrastructure of the virus, while POL provides the basic mechanism of retrovirus production. Right? That's what the two genes give you, while others just help enhance reproduction. And that stuff is actually taught earlier in, I think, the end of virology. Yeah, right here when they talk about HIV. Right, so page 175, this is where they talk about the different genes. The NV gene gives you the coding, the GAG stuff gives you the capsid matrix and all that stuff. The POL is the one that gives you all your enzymes. So this is the really problematic guy, right? This is the really problematic guy. If you can mess up that gene in HIV, they won't be able to make all these guys, and the virus is just not really going to do much. All right, and then they also teach you right here, homozygous CCR5 mutation will cause immunity. Okay, so that's a very significant thing, but we can't really cause mutations in ourselves to become immune to HIV. It's not a thing. So yeah, this page and the other one, I would definitely spend some good time on making sure you understand. HIV is a pretty high-yield topic for even step 1. You should be able to talk about those things from those two pages, the treatment one and the HIV one, without major issues. This test, as I'm going through NBME 18, I'm actually writing down questions I would have gotten wrong. This is one that I would have gotten wrong. So I would get to question number 10, I would get this wrong. In a study designed to test the effectiveness of a new drug in the treatment of endometriosis, 100 women were randomly assigned to one of two groups. 48 of the women received the new drug and 52 received standard therapy. The primary purpose of this method of assigning patients to different groups is to create which of the following. So the primary purpose. So I looked at the answer choices, double blind, single blind, 2 groups with similar sample size, and 2 groups with similar underlying characteristics. I told myself C made no sense because the sample sizes were not the same, so this must be obviously for double blinding, and I would have put A, but I would be wrong. The correct answer here is D, 2 groups with similar underlying characteristics. The 100 women were split unequally into 52 taking the standard drug, 48 taking the new drug. Since the sample sizes are different, C is immediately wrong. The only people blinded in this experiment are the women that are taking the drugs, because they do not know which drug they are taking, as far as I could tell from the question. But it is unclear from this question stem whether or not the experimenters and the scientists and the people collecting the data, if anyone else will know which drug each participant is taking. In a double-blind study, neither the experimenter nor the subjects will know, while in a single-blind study, only the experimenters will know. But the people taking the drugs, they'll never know. In this, the way this question is worded, I actually can't really tell if these 48 women even know, right? Because it says here 48 of the women were, they said that they were randomly assigned. But even though they were randomly assigned, did they know where they were assigned? Like, basically randomly assigned means that you randomly picked your subjects, right? But that just tells you that you didn't pick subjects who are sick, or specifically subjects who are of a certain age or a certain ethnicity, stuff like that. They were just randomly chosen women. But did the women know that they were taking the new drug or if they were taking the standard therapy? It's not clear here at all if anyone is even blinded. Okay, so since that was the case scenario, I should not have picked A, right? And 2 groups with similar underlying characteristics. Well, I mean, they were all of similar underlying characteristic anyway, because this is a drug for the treatment of endometriosis. So I'm pretty sure they didn't pick 100 women who don't have endometriosis. That would be really, useless. So all 100 of these women have endometriosis. How they were divided and stuff like that, I don't know. I mean, I don't want to say I'm biased into saying this is a bullshit question just because I got it wrong, but I do feel like it's a bullshit question because it isn't exactly clear what's happening, okay? And I've never heard of dividing people up into 2 groups just to create 2 groups with similar underlying characteristics. I don't see what underlying characteristics they're even focusing on. They just randomly chose to divide them up and not even divide them up evenly, which is kind of weird. So, that's NBME for you. 11, a 35-year-old primigravid woman at approximately 36 weeks gestation comes to the emergency department because of a 6-hour history of heavy vaginal bleeding. She has had no prenatal care. Ultrasonography shows that the placenta is located over the cervical os. Attempts to stop the bleeding are unsuccessful, and she undergoes cesarean delivery. Which of the following is the most likely diagnosis? This was a good, easy question. So they're telling you that you can see the placenta through the cervix. So this is placenta previa. All right, you're supposed to memorize this the first time you study it. You should never need to go back to this page again. This is one of those topics that you study one time and you perfectly memorize it and you never come back to this page again. So there's a bunch of different complications that you can have in pregnancy. Let's take a look at them. Our patient has placenta previa, which is right here. Right, this last one at the bottom. Right, placenta previa. So you can see how the placenta is going to be visible through the cervix. Right, attachment of the placenta to the lower uterine segment or under 2 centimeters from the internal cervical os. Risk factors of multiparity, prior C-sections, associated with the painless 3rd trimester bleeding. You get a preview of the placenta through the cervix. So that's how you remember placenta previa. I also added that it's associated with previous C-section deliveries. Very important to remember that. Now, NBME always picks the worst clinical scenarios because they actually gave you a patient who is a primigravid. She's never actually given birth before. So that's kind of rare to see, such a complication in a primigravid, because they tell you here that you would see this in a patient who has multiparity. Right? So, whatever. But they gave you enough to be able to pick the correct answer, right? You could see the placenta, so that's placenta previa. What are the other things? Morbidly adherent placenta is another one. That's a really problematic one. This one is super sticky. So that means your placenta is literally stuck to your body, the woman's body, right? Defective decidual layer. Make sure you remember that it's the decidua, not anything else. Leads to abnormal attachment and separation after delivery. Risk factors are, again, prior C-sections or any kind of uterine surgery involving the myometrium, inflammation, placenta previa, really old, or multiparity. 3 types distinguishable by depth of penetration. There's accreta, right? This one is the least penetrating. This one, accreta, attaches. It just attached to the myometrium. All right, that's the most common type. Placenta increta has actually gone into the myometrium, right? So attached to myometrium, into myometrium, and then percreta perforates the myometrium. So generally speaking, when the baby is born, placenta should come out too. It's not going to come out here, right? And because it's going to be stuck, it's going to cause excessive bleeding in the mother, and the mother can actually end up having Sheehan syndrome, right? Postpartum bleeding leading to Sheehan syndrome. That's your morbidly adherent. The opposite of that is one that's not sticking, right? Abruptio placentae. So when you're pregnant, you should not be bleeding from your vagina. Here, you would have premature separation of your placenta from the uterine wall before delivery, right? And you would have bleeding, right? So painful bleeding, okay, in the 3rd trimester. Possible DIC is also possible because of the tissue factor from all this bleeding. And you would have maternal shock, fetal distress, and both the mother and the fetus can die. Okay, so this is the opposite case scenario. Because the placenta has detached, this is no longer going to be providing enough blood supply and nutrients to the baby. So these are things you just study one time. You look at it one time, you're done. There's a couple more things on the next page: the vasa previa, postpartum hemorrhage, and ectopic pregnancy. You just look at it, you're done. You never need to come back to this page again. You're not going to have major issues remembering it. Vasa previa is the last thing. This is when the fetal vessels run over or in close proximity to the cervical os. So instead of the placenta being in the cervical os, now your fetal vessels are under the cervical os. You see? So this is vasa previa. Again, the previa stuff, just like placenta previa. Placenta previa means you had a preview of the placenta. Vasa previa means you have a preview of the vessels. Right? So you can see your blood vessels right here. This is another image I found online. Right, so you can see how the blood vessel, the placenta, no longer placenta previa, and you have your trifurcated umbilical cord, and you can see how that's kind of in the way of the cervical ox. Okay, that's not good. What is the problem with that? Well, this can result in vessel rupture, exsanguination, which is bleeding, and fetal death. Presents with triad of membrane rupture, painless vaginal bleeding, fetal bradycardia. Emergency C-section is usually indicated, frequently associated with a filamentous umbilical cord insertion, which is basically the cord inserting into the chorioamniotic membrane rather than the placenta. Right? And that's kind of what they're showing you here too. So the fetal vessels travel to the placenta unprotected by the Wharton jelly. All right, so that's really bad. Filamentous attachment. All right. So this was the rarest one. I've actually never seen a question on that, but it's worth knowing. Number 12 was a really cool question. I actually answered this correctly when I was trying to figure it out. When I do these explanations, I look at the question, I try to see what I would pick as an answer, then I try to figure out what the correct answer is from like various forums or anywhere else I can find the correct answers on. And that's what I'm doing in this explanation video. So anytime I got one of them wrong, I actually put it there. I got this one right, but a lot of people fell for it. So this is like NBME type stuff. They do this a lot. So 25-year-old man who has a history of facial flushing and rapid heart rate each time he consumes a small amount of alcohol participates in a study of alcohol intolerance. Molecular analysis shows the presence of a lysine for glutamate substitution in aldehyde dehydrogenase. The kinetic characteristics of the enzyme variants are shown in the table. Matching. For this one, I couldn't tell. I really couldn't tell. It might be matching. I don't know. But the way this question is worded, like that might be what they were trying to go for, but it's really not that clear. Alright. So this guy has alcohol intolerance. There's 2 different variants of some gene. There's molecular analysis is showing a lysine variant, which is the K487. And then a glutamate variant, which is the E487. That's the normal one, right? Native variant. In his aldehyde dehydrogenase, so this is why he's unable to drink, because every time he drinks, he gets this weird facial flushing and rapid heart rate. The kinetic characteristics of the enzyme variants are shown in the table below. Now, kinetic characteristics, we're supposed to know pharmacokinetics. But the one we don't know about is this one, K-cat. Based on these findings, which of the following is the most likely cause of this man's condition? So when I saw K-cat, I was like, I wonder what they're talking about, with cat. I looked at the answer choices and I figured out the cat is talking about catalytic efficiency. So I know Km. I know how Km works. Km is inverse to enzyme affinity, right? And if Km is high, right, then you have very low affinity. So you look at your answer choices: decreased catalytic efficiency of one or the other, increased catalytic of the other, less rapid turnover of E or more rapid turnover by K, tighter binding of NAD plus to K or weaker binding of NAD plus to E. So now we look at our table. E487 is the normal one, native variant. E487 has a very low Km compared to the other one for NAD plus. Low Km means higher affinity. So E487 really likes the NAD plus, whereas K487 does not like NAD plus. And you look at your answer choices, it's the other way around. So E and F are both wrong, but they're both good baiting answer choices. A lot of people picked either E or F. They fell for it. But they're both opposites. This one says tighter binding of NAD to K487, but K487 has a very high Km. It's going to have a weaker binding. And the other one says weaker binding of NAD to E487, but E487 has a low Km. It'll have a tighter binding. So it's the other way around. Now you cancel out E and F thanks to this first column. We don't see anything about rapid turnover, so maybe C and D are correct, but we can't really figure that out from the table. Then you look for the catalytic efficiency, right? So they tell you here that K catalytic efficiency of E487 is 180, whereas K catalytic efficiency for K487 is 9.5. And you're trying to figure out how you're supposed to work with these things. So the correct answer here was A, right? There's going to be a decreased catalytic efficiency of K487, which is very evident, right? The catalytic efficiency of K487 is 9.5. Right? This is not Km, this is Kcat. This is a lower number than 180, so 487 has a very low catalytic efficiency, which also explains why he doesn't have any tolerance. As soon as he drinks, he gets to facial flushing, he can't tolerate alcohol at all. The normal one is supposed to have a much higher catalytic efficiency. So when you see that, you just pick A, you move on. Km is inverse to the affinity, and you can see that K487 has a much higher Km. So K487 must have a weaker binding, and both E and F are wrong. They're opposites. K catalytic is the catalytic efficiency, which is lower in the mutated K487, which means it has decreased catalytic efficiency, so you just choose A and move on. Alright? As an added note, catalytic efficiency is actually calculated by dividing the numbers Kcat over Km, so 180 over 37. Right, 9.5 out of 5,600 is much less than 180 over 37. You didn't need to know that part to answer this question, but I just put it there anyway. Alright, so that's it for that. I'm not actually sure. But, I never really took this NBME, but from what I've seen online, yeah, I think a couple people said the same kind of thing, that it was pretty close to the real exam. But as far as I can tell, most NBMEs are pretty close to the real exam, so I don't really know what people are talking about. But I haven't finished looking at 18 yet. I'm only up to question 42. 13, this was a pretty easy question, but a lot of people got it wrong. An 82-year-old woman comes to the physician because of constant severe lower abdominal pain and fever for 24 hours. Laparoscopic examination shows severe diverticulosis and perforated diverticulitis. In spite of appropriate therapy, she dies 2 days later. Her liver at autopsy is shown in this gross image right here. Which of the following is the primary component of the material shown on the hepatic surface? So you look at our answer choices, you should know immediately. There should be no thinking about it. This is definitely not collagen type 1. Right? You can knock that out ASAP because collagen type 1 is more for bone, right? Page 50 in biochemistry is where they kind of tell you where all the collagens are, right? So type 1 is bone, skin, tendon, late wound repair. This is none of that. It's also not collagen type 3, but a lot of people were confused that was granulation tissue or something. It's not. It's not granulation tissue, okay? But yeah, type 3 is in blood vessels, uterus, fetal tissue, and granulation tissue. But this is not granulation tissue. A couple people fell for that. Here the answer was C. It's fibrin. You should know what fibronectin is, and you should know what proteoglycans are. Fibronectin has been the correct answer in a couple NBMEs, and it's been an answer choice in all the NBMEs I've done so far. The only answer choice you could possibly pick was fibrin. She probably had bacterial peritonitis leading to fibrin deposition. Type 1 collagen is on skin, bone, and tendons, while type 3 is in blood vessel, fetal tissue, and granulation tissue. Fibronectin, I showed you guys in another video I did before, is actually in this image here. In dermatology, you see the hemidesmosome. It has the integrin, fibronectin, laminin. Okay, so those are just parts of a hemidesmosome. Integrins, fibronectin, laminin. So that was just a bullshit answer choice. And proteoglycans, this is not relevant to that at all. So that was just another random answer choice. 14. A 52-year-old man has chronic pancreatitis. Deficiency of which of the following is the most likely cause of this patient's inability to digest triglycerides? Very interesting question. I don't know how many people answered this correctly, but everyone should have gotten this right. We're talking about digesting triglycerides, which is kind of like saying digesting lipids, and the only one that has digesting lipids is lipase. Colipase was the correct answer, right? If this answer choice was just lipase, everyone would have picked it. So just pick colipase. The others don't make any sense. Carbonic anhydrase, right? That is a hydrase. It's related to alkaline tide that increases blood pH after gastric acid secretion. It's also related to osteopetrosis, carbonic anhydrase 2, and it's related to aqueous humor production and CO2 transport in the blood, right? All of different parts. If you put carbonic anhydrase in the search bar and you start from the beginning, you can find every single place is mentioned. It's not relevant to digesting anything. Cholesterol ester hydrolase is for cholesterol, so you can just leave that alone. Monitor peptide is released by pancreatic acinar cells, and it actually stimulates CCK to release, and is more so related to rats. I had to Google it. I've never heard of monitor peptide. I would not even pick this answer choice because I've never heard of it. This was a bait answer choice, phospholipase A2, but you should have easily been able to knock that out because this is very high yield. Phospholipase A2 is the guy responsible for making arachidonic acid for leukotrienes and endoperoxides, right? If you look at that answer choice and you're like, oh yeah, I've seen that before, I just can't remember where you saw it right here. It's the guy that's the first guy, right? You take glucocorticoids to actually inhibit it. Okay, so that was completely irrelevant too. Colipase is not in first aid, but I actually had it as a note. And I think I had it as a note because I actually searched it up. Was it page 93? It discusses lipid transport, and 404. Okay, so page 404, which is page 367 in First Aid 2019. They just put lipases here, so I actually had to Google what the lipases are, and I listed them here. Right, so lipase, phospholipase A, and colipase, but not phospholipase A2. A2 is the one that's responsible for breaking down membrane lipids so you can actually make your leukotrienes and endoperoxides and all that. That's different. Alright? So I had colipase written here, but you should have been able to pick the correct answer either way. Colipase. The others didn't make any sense. 15 was an easy question. A 17-year-old boy is brought to the physician by his mother because she's concerned that his puberty is delayed. The mother states, he is so short, his father is 6 feet 5 inches tall, I don't understand why he has not had his growth spurt. When the mother leaves the room, the patient states, I'm fine, I don't know what's the matter with her, she wants me to be tall like my dad. The patient is 5'9" and weighs 70 kilograms. Excuse me. Sexual development is TAN stage 4. In addition to reassuring the mother that her son is fine, which by telling you this, they actually made the question easier, which of the following is the most appropriate initial statement by the physician to the mother? Now, this is a very common clinical scenario, not specifically for this case, but for many different cases. Oftentimes, a parent will bring one of their growing children into the clinic and tell you something's wrong. You can't just write them off and be like, your son is fine, like, what's wrong with you? Why'd you bring him here? Your son's fine, chill out. What's going to happen is that, first of all, you're going to discredit the parent, right? The parent wants to feel they were right. The parent should feel like they did the right thing by bringing their children in, you don't want to make the parent feel stupid, which is honestly how this mother is kind of acting, right? She's being a little stupid by wanting her son to be taller and complaining about his growth spurt or something like that. She's concerned though, she's not entirely just being stupid. She's very concerned, but I'm trying to make sure I can tackle all different mentalities that different people might have. So she's concerned about something. You don't want to completely discredit her, so you can't just be like, your son is fine, go home. That was an answer choice a lot of people wanted to pick. Your son is fine, just go home. Because now what that woman is going to do is say, wow, this doctor really doesn't care about my son as much as I do. Maybe I should go see another doctor, right? So what would you do here? A, since your son is fine with his height, you should try to accept him as he is. This was another answer choice a lot of people wanted to pick. You can't tell that to a mother. That's actually what we tell our mothers, right? Like, we tell our parents, like, can you just love me for who I am rather than telling me to be a fucking doctor, right? But that's just what parents do. They don't listen to you for accepting you as you are or whatever. So that answer choice was kind of a bait. It was wrong. B, tell me more about your concerns about your son's height. That is like the iconic classical answer choice UWorld has been teaching since the beginning of time. You keep it open-ended, you listen to the mother more, you pay attention to her concerns, you actually give her credit for bringing the child in and being concerned instead of just writing her off, right? So that was the correct answer. C, we'll do some blood tests just to be sure that all your son's hormone levels are okay. That was another bait of an answer choice, but doing blood tests on this 17-year-old, it's kind of unnecessary. You're going to end up just wasting resources. It's just not needed, and as a physician, those blood tests are going to come back fine. His Tanner stages are fine, his BMI is fine, his height is fine, he's not 5'2", right? D, your son is average for his height and weight. That is the correct answer. Like, in terms of, like, it's true, it's a fact. It's not the correct answer for this question, but it's a fact. Your son is average for his height and weight. But you can't say that to this mother, right? Because then you'd be discrediting her and you'd be doing all the things I just spoke about not doing. And then E, your son is not going to be any taller. Well, that's just fucked up to say. Like, unnecessary. So the correct answer for this question was B. A was a bait and D was another bait, right? So those are two different answer choices a lot of people wanted to pick. But B was the correct answer here. And it was pretty obvious just because of the way, tell me more about your concerns. That's something that UWorld has been pushing since day one. You want to tell your patient to tell you more. That's basically it. Let them talk. 16. A 68-year-old man comes to the physician because of a 1-month history of lightheadedness and tightness in his chest with exertion. He adds that the pain is worse after arguing with his wife, and the symptoms resolve with rest. He has a past history of lower GI bleeding. Evaluation at that time was negative on upper endoscopy and colonoscopy. His temperature is 37, pulse is 85, respirations are 15, and blood pressure is 110/75. Physical exam shows no abnormalities. His hemoglobin is 8.2, and hematocrit is 24%. Test of stool for occult blood is positive, okay? And ECG shows no abnormalities. Repeat colonoscopy also shows no abnormalities, and right there you're like, holy shit, right? Because something should have been wrong somewhere. Which of the following is the most likely cause of this patient's GI symptoms? You look at all your answer choices. Now, this was a really cool question. The answer here is angiodysplasia, and this is exactly how angiodysplasia presents, right? So the main thing in angiodysplasia is that all those tests are going to come back negative. There's nothing going to be there. And you should have been able to use those diagnostic tests to answer this question by knocking out the other answer choices, even if you didn't know what angiodysplasia is. For example, adenocarcinoma of the colon would definitely show something in colonoscopy. Diverticulitis would be seen on colonoscopy. Peutz-Jeghers syndrome, right? Answer choice D. That is an autosomal dominant syndrome with hamartomas in the GIT that you would see on colonoscopy. And then, of course, ulcerative colitis, you would see it on colonoscopy. So all these answer choices you would see on colonoscopy. So you knock them all out and you just go with angiodysplasia. And this question is very nicely worded because it actually shows all the symptoms of angiodysplasia. Angiodysplasia has tortuous dilation of vessels leading to hematochezia. It's often associated with the right colon of older patients and can be associated with aortic stenosis and von Willebrand disease. Two completely different things that you kind of would see on this patient. They did tell you that his ECG is normal. but that was kind of rude of them. It's, it shouldn't necessarily be normal, but again, aortic stenosis isn't necessary. It's often related to it. This patient's syncope and dyspnea, however, are probably related to the worsening aortic stenosis that he most likely has. It just didn't show up on ECG, maybe. Because remember, aortic stenosis is the sad thing, right? It has syncope, angina, and dyspnea. And pulsus parvis et tardus. That was another thing that is related to that. Other patients can have von Willebrand disease, which is going to lead to things like heavy menstruation, thrombocytopenia, etc. And von Willebrand disease is more common in females, whereas hemophilia is more common in males, at least as far as questions are concerned. The main giveaway here, though, was the normal colonoscopy. All the other answer choices would have been evident in the colonoscopy. So when we look at it in GIT, this is a topic that is pretty rarely tested, angiodysplasia, right here. Other intestinal disorders, right? They tell you associated with aortic stenosis and von Willebrand disease, confirmed by angiography, right? But I wrote here, look for a patient with aortic stenosis or von Willebrand disease with anemia and painless rectal bleeding with the normal colonoscopy. And that question we just did actually has this kind of patient, right? So it just worked out. Number 17, a 58-year-old woman comes to the physician because of a 6-month history of shortness of breath and chronic non-productive cough. She has a 2-year history of difficulty swallowing, joint stiffness, and diffuse tightening of the skin of the face, neck, shoulders, and arms and fingers. She's had a significant sensitivity to cold weather for 20 years, and she says that her hands turn white when they are exposed to the cold, which is Renal. Current medication includes histamine blocking agent for her long-standing esophageal reflux. 1 year ago, a biopsy specimen of the skin showed atrophy of the epidermis and deposition of dense collagen throughout the dermis with loss of dermal appendages. So they're describing everything that comes in Crest, right? This is all part of Crest syndrome. Examination of the hands shows cutaneous ulceration, claw-like flexion deformity, decreased joint mobility. This patient is at greatest risk for which of the following pulmonary disorders? So you look at all your answer choices. If you don't remember Crest syndrome, then you won't immediately know that the answer is F, pulmonary hypertension. If you do remember Crest, you'll pick it. But if you don't, then you have to now start knocking out answer choices, of which the first 2 you should knock out is A and G. Right? Crest is not related to adenocarcinoma or squamous cell carcinoma, otherwise you would definitely remember that. Like if it was related to that, always think of something like that. Like if you don't remember it, it probably wasn't true. That's also actually a fact. Because adenocarcinoma of the lung, squamous cell carcinoma, these are big, high-yield things that you've all been studying really hard. If you don't remember any association of that with Crest, it's probably because there wasn't one. So you knock that answer choice out. Bronchiectasis, if you remember it, you can knock that out. But bronchiectasis isn't relevant to Crest either. Granulomatous inflammation was a bait of an answer choice. You've done many questions on pan-acinar emphysema, many questions on pulmonary embolism. None of that ever had to do anything with Crest. So this was just pulmonary hypertension. This patient is exhibiting all the symptoms of Crest syndrome and has Raynaud's syndrome. First aid teaches scleroderma can also involve renal crisis, pulmonary fibrosis and hypertension, esophageal dysmotility and reflux, and cardiovascular symptoms. Everything is right here in musculoskeletal. Raynaud phenomenon, which is actually called Raynaud's syndrome when it's secondary to a disease process like Crest syndrome, is Raynaud disease if it's primary, idiopathic. And this patient had all the scleroderma stuff, right? And right here they tell you can involve other systems like renal, pulmonary. So you see the pulmonary hypertension, GI, cardiovascular, 75% female. Okay, and these were all the symptoms she was presenting with, stuff like this. All right, so not a bad question at all. 18. 27-year-old man comes to the physician for a psychiatric evaluation at the request of his new employer because his co-workers think he's very odd. He's employed as a computer repair specialist and lives alone. He refuses to socialize with anyone from work, and he has no friends that he sees regularly. He's extremely preoccupied with science fiction, the occult, and the afterlife, although he holds no particular religious beliefs. Which of the following personality disorders is the most likely explanation for his behavior? And then they put antisocial as a first answer choice because that's a bait. right? But he's not antisocial. First of all, when you're reading a question, really imagine it. Imagine that being you, a 27-year-old man working as a computer employee, and your coworkers think you're very odd, and your employer tells you, hey man, you should go get tested by a psychiatrist. Like, that's really awkward. That's beyond awkward. Like, that sucks, right? I'd be so embarrassed if someone seriously told me, you need to go see a psychiatrist. Everyone thinks you're a little weird. So this patient is sort of schizoid, right? He has that schizoid thing where you're like living alone and you're perfectly content with it, but you don't have schizoid as an answer choice because what he's presenting as is actually schizotypal because of his preoccupation with science fiction and the occult. The first sentence displays his interpersonal awkwardness, which is probably why his coworker suggested he get a psychiatric evaluation done, which in itself is also an awkward thing. Antisocial, borderline, histrionic, and narcissistic are cluster B. Paranoid is not a personality disorder, but rather a state of mind in which you are cautious of things. But this guy is schizotypal, answer choice E, which is on page 611. And this is also a topic that's been in every NBME, so I always talk about this page where, I associated cartoon images or someone with them, right? Some kind of character, not cartoon images. I associated a character with each cluster personality. Cluster A is this guy, the Tin Woodman from Wizard of Oz, right? He reminds you of someone who's either schizoid or schizotypal. Right? Someone schizoid has voluntary social withdrawal, limited emotional expression, and he's content with isolation. And you can see the limited emotional expression in this guy, right? Schizotypal is also this guy, eccentric appearance, odd beliefs, magical thinking, with Wizard of Oz, interpersonal awkwardness. Those are all the things that are true about our patient in our question. Cluster B is Cardi B, right? So you have the antisocial aspect where you have disregard for the rights of others, criminality, impulsivity. Now, I'm not saying anything bad about Cardi B. I'm just trying to, create an image that you can memorize. She might not actually have any of these cluster personalities. I'm just saying you can imagine it's true and then make it happen, right? Borderline, unstable mood, interpersonal relationships, histrionic, which is attention-seeking, and narcissistic, where you think you're the shit, right? Lacks empathy, requires excessive admiration, you are the best. And then cluster C is this guy from Big Bang Theory. His name is Sheldon Cooper, and in that TV show, if you haven't seen it, you're missing out, is basically he's a big-time physicist, he's a really intelligent scientist, and he's super smart, but he's not schizoid. He's actually dependent. He has an excessive need for support, low self-confidence, and he does get stuck into relationships where he's not actually happy. He's also very avoidant. He's hypersensitive to rejection. God forbid you tell him he's wrong, he's just going to lose it. Right? He's socially inhibited, and he desires relationships with others. As opposed to a schizoid where they are perfectly fine. Content with social isolation. They don't care for a relationship with others. Right? But Sheldon Cooper, he does get married, he does have a girlfriend, etc., etc. And OCD. Okay? Obsessive compulsive personality disorder. This is OCPD right here. Right? OCPD is a preoccupation with order, perfectionism, and control, egosyntonic, which means that the behavior is consistent with one's own beliefs and attitudes. Okay, so you think what you're doing is correct, versus OCD, where you're not right, but you really want to do it the way you like doing it. So there's a good, important difference you should be able to make between OCPD versus OCD. Always remember that. The egosyntonic versus egodystonic OCD. So that was it for that question. Number 19. This was also an easy question. An 8-month-old girl is brought to the physician by her mother because of a 3-week history of poor feeding, chronic diarrhea, and pale, foul-smelling stools. The mother says that the symptoms began with colicky abdominal pain following the introduction of solid food to the infant's diet. There is a family history of gluten sensitivity, which is celiac disease. She's at the 60th percentile for length and 25th percentile for weight, which doesn't tell you shit. Physical exam shows no other abnormalities. Dysfunction of which of the following cells is the most likely cause of this patient's symptoms? And then you look at all your answer choices. Now, all they gave you was the gluten sensitivity thing, and that's celiac. This baby probably also has celiac, right? The answer here was A, your enterocytes. it could not have been any of the other answer choices. Even if you didn't know, it couldn't be the other answer choices. Celiac disease has a HLA association in genetics, and this 8-month-old girl might also have celiac, right? Because celiac isn't autosomal dominant or anything, but it does have HLA stuff, so you can, have a family history that actually gets passed on. So in celiac, you have decreased mucosal absorption in the distal duodenum, making it difficult to absorb many vitamins and fats. This patient would not absorb D-xylose, and their blood and urine levels would be low because it would all just come out in the feces, right? Remember, the D-xylose absorption test is a way to test to see if you have injury to your actual lumen, your gut lumen, or are you missing pancreatic enzymes. D-xylose does not require pancreatic enzymes. So if your gut lumen is okay, you will absorb it and it will show up in your blood and your urine. But if your gut lumen is all fucked up, you're gonna not absorb D-xylose, and all the D-xylose you ate will just get pooped out. It will just go through your gut lumen into your colon and just come out. So that's how you would remember that D-xylose was one of the things related to celiac, and that was to test for enterocyte damage, actual damage to the lumen, and you would just pick this answer choice. Goblet cells just make mucus. Pannette cells just secrete defenses and lysozyme. They're very much like immune cells. Parietal cells are mainly related to pernicious anemia because of the intrinsic factor in vitamin B12. And serosal cells are just a garbage answer choice. It really had nothing to do with this question at all. Okay. Number 20, following an operation, a 65-year-old patient has a lung region that is underventilated but well perfused. This condition will lead to an increase in which of the following? So I'm going to stop at this question because this question actually has a lot to explain, and I don't want to make the video more than an hour and a half. This question was actually really nice because it taught you something that you might not have known. When I read this question, I was like, what the hell are they saying, right? So they're saying underventilated. So some region, because of this patient's operation, some region of their lung is ventilated less, right? So that means there's no air coming in, but it's well perfused, so there's a lot of blood there. What does that cause? Well, the lung physiology is unique compared to your other organs in the sense that you shunt blood away from places that are hypoxic, right? Underventilated means hypoxic. In the lung, if a certain part of your lung is hypoxic, you shunt blood away from there to another place that's more hypoxic. Less hypoxic, right? You send it to wherever the actual oxygen is because the function of the lung is to send blood to places where they can get oxygen, right? Your other body parts, so your other organs, if you have a hypoxic part of your other body organs, you end up sending more blood there because you would be bringing more oxygen to that location, right? So this was just a physiologic shunt. A physiologic shunt would occur in this patient's lung now, so that the lung no longer sends blood to this hypoxic part of the lung because that blood is not going to get oxygenated, and then the lung wouldn't be doing its function, right? This was a very interesting question where a lot of people fell for anatomic dead space, a lot of people fell for alveolar dead space, some even fell for physiologic dead space, which is, like, how do you have physiologic dead space? Physiologic dead space is normal dead space, which all of us have, but this is not physiologic anymore. He had an operation. And so I think the most commonly picked answer choice was anatomic dead space because it seems pretty anatomical, so anatomic dead space is going to increase. Okay, so how do you explain this? I'm going to show you pictures in my book. Page 735 has an image with the physiologic intrapulmonary shunt with VQ mismatch. They describe this patient will now have a VQ mismatch, so blood will be shunted to the better ventilated portions of the lung. That's all you had to think of for this question. Physiologic dead space is anatomic dead space plus alveolar dead space. So you see how all the answer choices are pretty much the same thing? Right? Physiologic dead space is anatomic dead space plus alveolar dead space, which is all air that does not take part in gas exchange. So what's the trick here? Remember that when ventilation is 0, but perfusion is okay, that is due to some airway obstruction, like a foreign body aspiration, so a shunt will occur. That's what's happening with our patient, right? Ventilation is 0, right? Underventilated. Or ventilation is approaching 0, right? But perfusion is okay. So any kind of issue where you have this, you're going to have a shunt. And in these patients, 100% oxygen will not help. When ventilation is okay, but perfusion is approaching 0, that is due to some blood flow obstruction, which increases physiologic dead space, such as a pulmonary embolism. And in those patients, giving 100% oxygen does help. So remember that dead space has air, but no blood, unlike our patient. Our patient does not have air, right? So you couldn't pick any dead space answer choices. Dead space is related to having air, but no blood, and that's why we have dead spaces at the top of our lungs, right? At the top of our lungs, because of gravity pulling blood down to the base of our lungs. Majority of the blood goes to the base of our lungs, but there's a lot of air at the top of our lungs that doesn't get into blood. It does not get into, it doesn't get picked up by our red blood cells. That is physiologic, normal dead space that all of us have. All right, so now if we go to page 735, we get to see shunting, right? This is one anatomic shunting due to bronchial circulation, right? Deoxygenated bronchial blood coming into here, right? This is related to, I think, this first question right here, right? U-World, a graph is given depicting low partial pressure of oxygen in systemic venous blood, high in alveolar capillary blood, and slightly lower in the systemic arterial blood. What factor most likely explains the change in partial pressure between alveolar capillary blood and systemic arterial blood? So what basically happened is they had a graph. I think if you guys have done it, you probably remember the question. There was a weird graph where they showed amount of oxygen in your blood. It was low, then it got high, and then it got slightly lower. And they wanted to know why this part happened. Well, this part happened because you added more deoxygenated blood at this weird shunting area. Now, for our patient, that's not the shunt we're talking about. Our patient is having this shunt, right? Physiologic intrapulmonary shunting with a VQ mismatch. What happened here? Well, this one alveoli in this graphical illustration, there's no air, right? Because of maybe fluid and debris filled alveoli, such as consolidation, right? Our patient has a different reason. Our patient probably doesn't even have this alveoli. Remember, this is just a graphical illustration. But in our patient, they probably don't even have, this section because of the surgery they had. So what happens now? Well, because, there's no air here, you stop sending blood there. Right? So you see how the normal one is in the middle. It's supposed to be 104/40. Right? You stop sending blood there. You're not really going to send much blood in that direction. You're going to shunt the blood to the other better ventilated areas and not send it to this hypoxic alveoli. That's what's happening with our patient. Okay? All these other scenarios, though, if you look, all these other scenarios, generally speaking, besides this one, besides the one on the bottom left, all these other scenarios, generally speaking, have air. They have air in the alveoli, right? And when you have those things, then the issue is usually something else with the blood supply. Like here you have a pulmonary embolism. This one had decreased alveolar ventilation, maybe because the patient has respiratory depression. They're not breathing enough. You're still not really shunting blood. You see, there's no blood shunt. You're still sending the blood in the same kind of way. And you're going to have a normal AA gradient. It's just you're not really breathing in enough, so your air in your blood is also low. Okay? Decreased alveolar. Remember the concept of AA gradients. If you have a high altitude or if you have hypoventilation, like that image we just looked at, your AA gradient is going to be normal. AA gradient actually only increases in a VQ mismatch, any kind of fibrosis because you have a diffusion limitation, or a right to left shunt. Right? And a right to left shunt is the case we have right here with our patient. Right? So you see high AA gradient. Right? The AA gradient increased because you have 104 air here, right? But only 70 at the end over here because this one didn't pick up any air. The average went down. This is not supposed to be 70 here. Okay? So that's generally it for this. Make sure you spend good time. I haven't done my respiratory new videos in the new playlist, but I do have respiratory videos up already where I explained most of these, went through these URL diagrams, did all the questions here. But I have added a bunch of new stuff, so when the new videos come up, it's going to be a lot better because some of these things weren't there before, and they're definitely going to help make the material a lot easier. Alright, so I'll stop here at number 20 for now. I'll be live again tomorrow at noon to continue this. And when I do continue tomorrow, I'll first fix the explanation for number 2, because I kind of misexplained it here. And then we'll continue on to the rest of this. Alright, so thanks a lot for joining, and I'll see you guys tomorrow.